Good afternoon. Welcome to the commission meeting. I'm Wendy Everett. I'm the vice chair of the commission, and I'm sitting in today for Chairman Altman, who is out of the country on both work, and since he's in Africa, we're going to assume maybe there's a little bit of pleasure associated with it. So we have a terrific agenda today, and if we could move to that, let me just quickly go through. We'll start with the approval from minutes of the last meeting. And then David Seltz will go over the current plans for the cost trends hearing in October. And we're really pleased to have Ray Campbell with us today to present the results of CHIA's report on the performance of the Massachusetts healthcare system. And then we're going to finish up with something that is always really fun and exciting, and that's hearing from one of our grantees. The Brookline Community Mental Health Center is going to spend some time telling us about what they've accomplished. So that's today's agenda. And let me just start with the minutes and the approval of the minutes. Before I ask for a motion, I do just want to commend the staff. I know minutes are sometimes not the highlight of our meetings. And at the same time, if you had a chance to really read these, the staff just did an extraordinary job of capturing a very complex, difficult discussion about the CMIR. And I want to commend you not only for paying attention to all of the opinions of the commissioners, but also capturing it in such a way that it was eminently readable later on. Not exactly a short story, but very helpful. So with that said, could I have a motion to approve the minutes? Second, thank you. Any additions or corrections? Great, all in favor? Thanks. Okay. So I'm going at this moment to turn it over to David Seltz, and you can, I started to say Commissioner Seltz, just almost got a promotion there. And you can give us the intro to the current state of the cost trends hearings.
Yeah, commissioners don't pay quite as well. Thank you everyone for being here, and first of all, just wanted to say thank you to Ray Campbell and to the CHIA team who are going to be presenting here today. Just a tremendous job and an accomplishment by the entire organization in putting this report together. And as you will see shortly, some very significant numbers and trends for our consideration of how Massachusetts is performing under the benchmark and under this healthcare cost containment effort. And I think the report provides a really important milestone in this ongoing effort to restrain healthcare spending growth and improve affordability. And I think we'll spend some time talking about today some really positive trends and numbers and some continued areas for some concern. Just in terms of some housekeeping, I just did want to note that we do have a second HPC board meeting scheduled for September 27th, which is a Thursday, at which time we do plan to consider the final cost and market impacts report for the Beth Israel Leahy transaction. So that will be the primary agenda item at that meeting on September 27th. So for today, before we jump into CHIA's report, I did want to give an update on the cost trends hearings. And for that, I'm going to turn it over to the HPC's Deputy Executive Director, Colleen Ostermeyer.
Great, thank you, David. Also just wanted to note that Thursday, September 27th board meeting is at 11 a.m. So we're trying to throw you off with both a Thursday and a non-noon start time. So great. So I'm here to give you all a high-level preview of the HPC's 6th annual healthcare cost trends hearing. This will be held on Tuesday and Wednesday, October 16th and 17th, again at Suffolk Law School at 120 Tremont Street. As always, we're expecting extremely high attendance, high participation rate amongst our stakeholders. The registration link is open. You can reserve your seat. I can't read it from here, but the registration link is on the save the date at the bottom of that link. We actually already have 200 registrants, so also want to highlight that again this year we will be live streaming the hearing. That'll be available on our website directly starting the morning of Tuesday morning. So we're excited to have confirmed Governor Charlie Baker, Attorney General Maura Healey, both will be coming to offer their remarks at the hearing. The governor will be the first day and Attorney General Healey will be the second day. We're also having remarks from State Auditor Bump, who is an HPC appointing authority along with the governor and the Attorney General. And we've also extended invitations to legislative leadership and plan to confirm their participation in the next few weeks. So we're excited to have the attendance and the support of all of the state leadership again this year. For guest speakers this year, we've invited Dr. Ashish Jha, who's local to the Boston area, and many of our commissioners know personally, and many of you are familiar with his work on healthcare spending trends in the United States. He's currently the director of the Harvard Global Health Institute, and his role extends through Harvard as the dean and professor of medicine and global health. He's also a practicing general internist, which is great. Most recently, many of you are familiar with the landmark JAMA article he published in April of this year with several of his colleagues examining healthcare spending in the U.S. compared to other high-income countries and how trends in utilization are driving those driving the differences between spending in the U.S. and those other countries. So we're thrilled to hear more about his research and perspective at this year's hearing. And continuing on the first day from a state perspective, we'll have Director Campbell and our own Director of Research, Dr. David Auerbach. You'll be getting a preview of Director Campbell's presentation here today, and they'll be delivering the research on spending and trends in the Massachusetts healthcare system. Continuing on day one, we're planning the following themes and topics, as always looking for commissioner feedback and input on those themes and topics. So the planned theme of day one, similar to years past, is meeting the healthcare cost growth benchmark, focusing on the top trends in care delivery and payment reform for that first kickoff panel. And then in the afternoon, building off recent research issued by the HPC about significant growth in urgent care centers in Massachusetts, we are considering a second panel focused on this emerging market and other new models of access to convenient and timely care, both for non-emergent primary care and also for mental health and substance abuse through models like local integrated health and telemedicine. So that's the focus of the second panel of the first day. Also on the first day, as always, there will be an opportunity for public testimony, which we will open up the list as soon as we arrive at Suffolk that day, so please sign up. So that's the first day. I don't know if anyone has comments on the first day, if you just want me to go ahead right to the second day. Okay. So on the second day, we've invited Trish Riley, who many of you know as well. She's the executive director of the National Academy for State Health Policy, NASHP. NASHP is a nonpartisan forum of health policymakers from state governments all over the country. So we're inviting Trish again to bring a national perspective on what other states are doing. So she's going to be delivering remarks focused on state solutions to a variety of health policy issues, including pharmaceutical drug cost concerns, delivery system and payment reform, and whatever else are the emerging cutting-edge trends that other states are pursuing to solve their health policy issues. The witness panel themes we're considering on day two will include reactions to several spotlight issues and hot topics in the state. So in addition to any feedback we received from commissioners today or over the course of planning of this hearing, we'll also be drawing from the pre-filed testimony or PFT process to determine the themes of day two. Each year, as you know, as part of the cost trends hearing, many in the audience know, the HPC along with CHIA and the Attorney General request pre-filed testimony from our healthcare stakeholders. We sent out PFT requests this year to 36 provider orgs and hospitals and 14 payers across the Commonwealth. So the PFT and the in-person testimony is really what we use throughout the whole year to inform our research topics and our cost trend support especially. So these are both really important, two sides of the same coin. So the PFT is due this Friday. We've had a number of extension requests, but when it comes in, we'll post it to our website immediately. So look at Friday at 5 p.m. to see who can meet deadlines and who needed an extension. So that said, next week we're planning to release the full cost trends hearing agenda. And just a PSA, if you are an industry participant and you have not been called yet to testify, it doesn't mean you won't be called to testify. I've heard from many of you, you're not a shy bunch, so feel free to reach out to me if you want a heads up whether or not you'll be called to testify this year. And obviously a big part of the hearings is about the state's ability to meet the healthcare cost growth benchmark. So during Ray's presentation, we asked that you think of themes that you'd like us to address at the hearings or address through the cost rooms report this year. Things that are worthy of further examination. Any questions? Are we excited?
We're excited. Great, we are so excited. Great, thank you.
Great.
That's a great summary and nice to have a preview of the specific panels and the topics. So thanks a lot. Okay. Great. So at this point, we're really pleased to welcome Ray Campbell to talk about CHIA's report. David, did you want to make any initial response, or we're just going to move right on to Ray?
I think we can move right into what we're all here to find out.
Great, thanks. Well, especially Colleen, with that great introduction to the cost trends hearings. Ray, we're really pleased that you are here to share with us some of the data that will inform the hearings, and really look forward to your report.
Great, thank you. So,
Sure.
I'm sure I was close enough to go do it. Thank you, Chairwoman Everett, Commissioners, Executive Director Seltz, and I was going to say Deputy Executive Director Helstemeier, but Director of Research Auerbach.
Okay, you can stop there.
Exactly. It's a pleasure to be here. Thank you so much for having me. Looking forward to presenting the results of, or giving you a summary of CHIA's annual report. I want to emphasize that, of course, the report in full is available online now, and in addition to the report itself, which is quite a bit more extensive than what I'll go through here today, there's multiple data books and other appendices related to it. So there's quite a bit of information. This is only the tip of that particular iceberg. Okay, before getting into the actual numbers, I just want to pause excuse me, on this slide for 1 second. The top part of it, I think I have addressed. The first bullet point in terms of this is really a great high-level overview of the state's healthcare system, and that I want to raise an issue about the data that we use to do that, because a lot of the questions that you'll ask are ability to answer period, and then there's a certain amount of time you need to just assemble the data, massage it, do the analysis, and produce a report, and that just wouldn't work for the time frames that are required here. So CHIA does a completely separate data collection process from the payers in the state at an aggregate level, not looking at claims data, but at an aggregate level, where we collect information on how much they spent by service category, by product type, and a whole bunch of other dimensions. So this is actually a high-level view that no other state can assemble. I'm not aware of any of the states that have this kind of a system-wide measurement exercise that goes on. Some states are now trying to use the all-payer claims database to do that. It would involve so much uncertainty and so many assumptions. It's an interesting exercise, but there's nothing like being able to actually measure the full system the way we do. Having said that, you'll have questions that you want us to drill down on, that the way we ask these questions, you can't because it's aggregate data. But we can drill down on them with the all-payer claims database. So it's almost like we have to shift engines. So this report tees up a lot of issues, and you'll have a bunch of questions. But the truth is the Health Policy Commission, CHIA, and others can use this data and the other data sources like the all-payer claims database to drill down in greater and greater detail. So this tees up the issues, and then we can go further from there. So just wanted to make that point that there's a key point here about the data sources involved in this report. So getting right into it, this is in some ways the top line slide that people are often most interested in. Total healthcare expenditures in Massachusetts in 2017 were $61.1 billion. That works out to $8,907 per capita, and the growth rate per capita from 2016 to 2017 was 1.6%, in other words, well below the benchmark. I guess I should mention, since we're talking per capita, it's worthwhile context to have in the back of your mind. Massachusetts population grew by 0.5% from 2016 to 2017. Okay, so looking at the trend, this slide puts the 2017 numbers in some context of the prior numbers. And this shows only the prior finals rather than the prior, we've got other slides where we showed the initial estimate and the final. So this only shows the final, but it's a fairly, at least as far as it goes, for 5 years, a fairly clear trend where we had 3 years of increasing medical cost expenditures in the state. And for the last 2 years, we've had decelerating, both years being below the benchmark, and this year's initial 1.7% being particularly notable. It is also, I think, worth pointing out, we can start drilling in on any of these points, but the 2014 and 15 higher growth rates did coincide with a bunch of ACA implementation activities, Medicaid expansion, temporary mass health membership, and a bunch of things like that that would influence the numbers.
So Ray, before you go on, the 1.6% number is to be celebrated, certainly, and terrific in that it's that far below our benchmark. How predictive is the interim number of the final number? So as you look back over the past 3 or 4 years, as there has been an interim number, has it changed dramatically when you had final numbers? Or can we take this 1.6% as being pretty close to what the final number will be?
I think so. That's a question.
Before we get too excited about this.
Right, exactly. This is something that we're looking at. The preliminaries versus the finals, to give you a sense of how they varied. In 2014, the preliminary is 4.8% and the final was 4.2%, so there was a 0.6% change. The following year, in 2015, the preliminary was 4.1% and the final was 4.8%, so a 0.7% change. Last year, there was only a 0.2% change. And then, of course, this year we don't know. We can say that looking at the past years, most of the error has come just from payer data submission issues. This is not, they don't slice their data this way for any other particular purpose. And so it is subject to some amount of uncertainty, and different ones comply with our data specs slightly differently. It seems as though they're getting better at the data submission over time, and we're getting better at it. And so I think if anything, we would expect this number to not show a large variation when we see the final next year. I mean, I guess anything can happen, famous last words, but my prediction is that this would be pretty close to the final.
Great, thank you.
All right, so now we'll start digging into the components of total healthcare expenditure and what they can tell us about the changes in spending and what's driving it. So this particular slide breaks down the $61.1 billion into the 3 major insurance categories, plus net cost of private health insurance and other public programs, primarily the health safety net and the VA. So you can see that Mass Health and Medicare combined account for more than half of the market, although the commercial is the single largest segment. The growth rates you can see in the pie chart, 3.1% for the commercial market. Mass Health declined by 0.2%. We'll dig into that some more. And Medicare increased by 1.9%. The smaller slice is net cost of private health insurance. You see a 10.2% increase, and other public programs increased by 5.3%. Yeah, 5.3%.
What is the net cost of private health insurance? What are you measuring there?
I mean, that's all the payments that occur that are not that's everything other than the payments from, that's everything other than the payments from payers to providers. So it's the administrative costs essentially of the health plans. It's the, in terms of medical loss ratio, it's the non-medical expenditures. But what we have slides in the annual report, I don't think in this slide deck, but in the annual report, that look, this varies quite a bit from year to year. And I think since CHIA has been collecting the data, it's gone from increasing to decreasing to increasing to decreasing. And this is subject to a lot of underwriting and actuarial type of stuff. And so it's not growing, I don't believe, overall. It's just, it shows more fluctuation than you see inside of the insurance categories. Because things like risk adjustment payments that might fall on one side or another of a fiscal year, those go in. It's not just administrative costs, it's anything that's not paying a provider for care. So all of those non-medical payments are in there.
Would you mind just turning on your microphone so people can hear? Thanks.
Sorry about that. Do you break commercial down by individuals, small company, large company?
Absolutely, we go into a whole bunch of detail on that. So yeah,
What's the biggest trend that you see within commercial of the various groups?
in terms of membership enrollment, I can go.
In terms of cost, in terms of increases in costs, where do you see?
We have a specific slide. So yeah, they just hold on. We'll get right. Yep. So, and what we'll do first is we'll go through the public part. So we've talked, at least we've put out now the big picture of 1.6% growth across the entire healthcare economy. We've now said there's really three big spending components there: commercial, mass health, Medicare. We're going to look first at the public payers, then we'll switch to the commercial market and dig into all those pieces. So turning first, and this is still, we're looking at the whole market here before digging into the components. So this shows, whereas the last slide broke out the spending by the insurance categories, where you saw the three major payers, this looks at the medical spending piece of it by the service category. So what you see is, here's where I actually did have my own report. Easier.
You memorized 100 some pages.
Exactly. No, not yet. Actually, yeah. I realize I still am working off the draft that I made notes on a week ago, so it has a different version of this slide. So, but anyway, what this slide shows is the blue bars are the 2017 total amount of spending. The numbers in the orange circle is the growth rate from 2016 to 2017. The light gray bar shows the 2016 spending, and the gray number is the 2016 growth rate. What you see is, everything grew, I guess other than other and non-claims. But of the major service categories, everything grew, but spending growth was down across all of the categories. And so to break that out a little bit more, so you see the hospital inpatient grew by 0.9%, hospital outpatient grew by 4.8%, physician services by 1.2%, pharmacy spending by 5%, other professional services by 2%, and then the other category declined by 3.1%, and non-claims payments declined by 2.9%. So, although from a service category perspective, when we look at these, it's worth considering that if you added the hospital inpatient, it's very worthwhile breaking them out. But if you added them, it would give you a sense of the size of the hospital component of the system. In some sense, by breaking out inpatient and outpatient, it kind of separates out that size.
That was particularly helpful in that we know we've had a major issue with pharmacy costs and the increase, but the hospital outpatient costs are almost equal to pharmacy. So it was really helpful to display it this way on the slide, capture a lot of information.
Great, thanks. Glad it was useful. And I should say, and we always caution, we put out the numbers to have a more informed public policy discussion around healthcare and healthcare costs and things like that. The numbers themselves aren't inherently good or bad. And in particular, you have to be, as we look at them, for instance, 4.8% in hospital outpatient, does that reflect a favorable shift of services from an inpatient setting to an outpatient setting or not? Or is it just that the prices of outpatient services have increased? That's a case, it's an example of where the data we collected for this report can't answer that, but the all-payer claims database very probably can. The Health Policy Commission, I think, has expressed, perhaps it was people at CHIA, some people have expressed interest in digging deeper into this question of the growth in outpatient and what it is that's driving it. So it's a case where this high-level analysis can identify issues, and then we can go back with other tools and do a deeper dive.
Wait, what about the long-term care and rehab stuff? Is that in the other professional, or is it outpatient? I think, wasn't there something that captured last report?
Yes, when we turn to the mass health spending, you'll actually see by their breakdown, their service categories, but I believe other captures things like that, right? Yeah, things like that. And when you go to the commercial insurers, you'll see that their service breakdown has a very small other category, and for mass health, it's a very large other category. Thank you. You're welcome. So I think that's that pharmacy number, by the way, I should mention is not net of rebates. So in other words, rebates are not yet factored in. The report has a deeper dive on prescription drug spending and the impact of rebates. This is the second year that we've done that. We worked closely with the trade associations to make sure that we were, that our methodology and not just the trade associations, kind of anybody, to make sure that we had a good methodology for accounting for rebates. And as far as it goes, people endorse it. And so if you look at spending net of rebates, it's 4.1% rather than 5%. We also, and pretty much every slide that you see here is the tip of an iceberg, with much more information in the report itself. But this is a look at the adoption of alternative payment methods across different types of insurance categories. We reformulated this slide from the way it was in the past, which I like because it shows the bars as a percent of 100%, whereas before they kind of lacked that context. And so I think we've done a good job, in some levels of adopting alternative payment methods, but it also pretty clearly shows that they're stuck at, only in the high 30s, 30, 40% of the market. Now you do see with Mass Health, you see the PCC plan 2017, a sharp increase in the number of member months under alternative payment methods. That's actually not the ACO rollout, that's a ACO pilot, but in 2018, March of 2018, the ACO program rolled out. So next year when we show the 2018 data, you'll see kind of that spike will still be there, but it'll actually be from the full program rather than from a pilot. But we don't have a great sense at CHIA, Mass Health might very well, of what that number is likely to look like, but we'll be tracking it and reporting on it. And then other than that, it was fairly stable. I think in the commercial market, we did see growth in the PPO segment, but otherwise adoption was fairly stable or declining. Okay, so now we can turn to the public programs and look a bit more at those. So Mass Health total spending statewide in 2017 was $17.2 billion. That's actually a decline of 0.2%, and that's total spending, not per capita. If you adjust it to be on a member month basis, or I'm sorry, there was a 2.4% decline in member months. So if you factor that in, there was actually an increase in per member per month spending by Mass Health, but the 2.4% decline in member months resulted in a 0.2% decline in overall spending. That decline in member months was driven by program integrity activities at Mass Health and other program management functions. So we wouldn't expect to see those producing ongoing results. It's sort of a one-time probably correction, but not something that they would repeat year after year. But as is the case pretty much with any of these Mass Health things, that they have a better insight into it than we do at CHIA.
Do you know what that dollar amount is?
The dollar amount of
With the reduction of 0.2% in spending will be?
yeah. So last year it would have been. Oh, actually, I think we might have a slide. Well, it was 17.3 billion, and it's down to 17.2. I think I only have it to one decimal, but yeah, from 17.3 to 17.2.
Right, can I just make one clarification?
Sure.
It is, our program integrity efforts is certainly not a one-time thing. We continue to kind of focus on program integrity and looking at enrollment trends, but as you said, we don't expect to see this drop in enrollment year after year.
Thank you. Great correction. Program integrity goes on because diminished, but the savings associated with this one particular year is not going to be a year after year. Right. Thank you.
And Warren, can I ask you a question? As part of program integrity, is it redetermination of eligibility? Is that one of the
Yeah, so
steps in that?
it's the, during this time period, we automated redeterminations. There was a fix to the HICS eligibility system, but it also includes other program integrity initiatives like using a TPL for PSS services. The new utilization management for home health services was also implemented during this time period. So it reflects not only enrollment and recommendations, but it's other program integrity initiatives that we really focus on and implemented that over that 2000.
So continuing to look, take a deeper look at Mass Health. Now, this particular slide is only looking at the Mass Health MCO spending, and you can see the circled pie chart in the lower left. Gives you a sense of the fraction of Mass Health total spending that's covered by the MCO. So it's just under half. And the reason we focus on this is that a lot of Mass Health spending does not really equate to or compare to commercial spending. This is the piece of Mass Health that sort of looks most like it, so we do the breakout service category breakout here that we don't do elsewhere. So anyway, looking at the MCO service categories, what you see is it's different than just quickly clicking back to the commercial service categories that look like this. You see that the mass health service categories look different. You have inpatient and outpatient at almost exactly the same.
You can take a moment to phone.
Yeah. I kind of thought I'd have the slides a little more in front of me, so I can't quite read them from here. I need to pull on my hard copy. There. Okay, now I have a hard copy. Not wait, I still have a hard copy. I just hadn't brought it up. Okay. So what you see is of these service categories, inpatient and outpatient, just about the same growth in those two categories, very restrained, 1%, 0.4% and 1% respectively. You see pharmacy spending, however, increasing, and this is only the MCO portion of it, and that's why the number is larger than for the mass health population as a whole. But you see pharmacy spending increasing 13%. That too is without accounting for the impact of rebates. And that makes it now the largest single service category in the mass health program. Other professional services and other for the MCO populations are relatively low, and non-claims payments are relatively high.
Do we know what non-claims payments are?
In the mass health space, MCO world, I defer to Lauren for.
I believe, from you, CHIA is categorized as the like pay-for-performance payments.
I think, yes, that's what I'm saying. Yeah. So is this true? Yeah, for commercial, for sure, this is fair point. You asked me, and I was thinking commercial, but for mass health, it's the same, I guess. Things like non-claims payments are like pay-for-performance or shared savings or global payments or things like that, things that are not claims-based.
And Ray, and maybe this is an unfair question to Lauren because she hasn't seen it yet, but do you have any sense as to what's driving the pharmaceutical costs, since they're so much higher than the commercial costs? The commercial costs percent was about 5%, 13%, a dramatic difference. Do you have any sense of what's driving that?
We took a quick look. I mean, I think Mass Health understands that a lot better than we do. I think the one thing that we would know is that they're covering a really complex and sick population compared to commercial payers by and large. So it definitely impacts, like this is not risk adjusted, this spending. So you might look at it and say, why are they spending so much more? If you adjusted it for the sickness and the complexity of the conditions that their patients are in, or their members are encountering, it may not look different at all. So I'm not sure. Did you guys
Yeah,
have a sense
I
of
would
what
just
you're?
add at kind of a high level, I mean, Mass Health is required to cover all pharmaceuticals that are, and all drugs that are approved, and so we don't necessarily have the same negotiating and contracting levers as the commercial market does.
Right, I think specialty drugs are a big part of this. Some of the high-end specialty drugs that have come online that frankly, mass health population, the prevalence of some of these conditions will be potentially higher among the mass health population. So I think specialty drug spending is probably a part of that as well. So things like that.
Great, both of those explanations are really helpful. I think particularly as you framed this, these data will inform our policy discussions and our choice of issues going forward. So helpful to understand even at a high level what's driving some of these numbers. Thank you.
Looking at Medicare, we don't dive deeply into this because it's a program that's not really susceptible to state intervention, so it's an important part of the landscape, but it's somewhat immutable in that sense. So it's $17 billion in spending, just a little bit smaller than Mass Health, 1.9% growth rate, as we had noted, and a 2.4% increase in beneficiaries for the year. So that means that they actually had a decline in per member per month or per beneficiary a year, however it's measured. Medicare compared to Medicaid, Mass Health Medicaid, where although the enrollment decline caused a spending decline, the per member per month was up at Mass Health. So a slight difference in terms of the trend in Mass Health and in Medicare.
Well, also, I can't draw any conclusions from this, but also interesting in that you have almost a 2.5% increase in beneficiaries. And at the same time, I think you said there was only a 0.6% in growth increase in the population.
0.5, right, good point,
0.5.
yes.
So it's going way too far than I should go to extrapolate and say that could be a reflection of the aging of the population in the state, and what will that mean over the next several years for the demographics
Great point.
and the push on the healthcare system, greater push on the healthcare system.
Wendy, I would note that we did talk about that at the benchmark hearing, and we expect that to be pretty much 2% every year. And that the aging of the state population will add about 0.5% to benchmark each year. That's just baked into our demographics.
You know, this really puts it in vast relief there. Thanks, David.
All right, just one other slide on the Medicare program where it shows the rough breakout, which has been stable over the 2 years of Medicare fee-for-service versus Medicare Advantage. I was speaking with somebody from Rhode Island the other day. I was surprised to learn there the ratio is essentially flipped, that almost everybody's in Medicare Advantage and very few in fee-for-service. So I don't know what the national numbers are, but just that's the Massachusetts. And you see that the growth rate is essentially comparable in the two types of payment programs. Okay, so now turning to commercial insurance, where we can start to get at some of the questions that you were interested in, Ron. You guys were just name tags, just FYI. Little plausible deniability. All right, so looking at commercial insurance, which as we said earlier, let me pause on this slide. So commercial spending on commercial insurance accounted for a total $22.8 billion in 2017. That was up 3.1% total, but there was a 0.4% increase in member months. And so the actual per capita increase in spending in the commercial market was lower. I think it was like 2.9%. I'm not sure. Well, I can circle back on that if I find it. But so that's the I love this slide in the commercial market. So looking at the commercial market from a service category perspective, you once again see it's different than the slide we showed of the total market and different than the service category breakout of the mass health population. So here you see hospital outpatient is significantly larger than hospital inpatient, and physician services are approximately tied or approximately the same size as hospital outpatient. The growth rate was highest in the hospital outpatient sector. It was only 0.8% inpatient and only 0.4% in the physician space, but it was 4.6% in hospital outpatient. Once again, we caution people to not rush to conclusions about any particular number, because the first explanation isn't always correct, because it could reflect a positive shifting of site of service, or it could reflect, a negative trend. So that's why it's the type of thing you may well want to follow up on when you see a number like this. So 4.6% is the hospital outpatient, 3.2% on pharmacy, and then the other smaller categories, you do see some larger numbers, but they often fluctuate more year to year. Okay, so now looking at, we're pivoting to start looking at more kind of affordability, less about how the money is spent and more on kind of how the coverage is purchased. And so here, this slide looks at high deductible health plans, and in particular breaks it out by market sector. And it's an interesting and telling slide because growth or adoption of high deductible health plans continued very strongly in 2017. So what you now see is that they've grown to the point where it's 28.2% of the market. So not, more than a quarter and closing in on a third. So a very significant proportion of the market. It's definitely not a niche phenomenon. It's a significant part of the market. If you look at the breakdown by market segment, you see 74% of unsubsidized individual purchasers are buying high deductible health plans. And the tier, the ranking of the adoption rates by market segment is kind of a pure 1-to-1 based on size. It's 74% for the unsubsidized individuals, 57.5% for small, 51% for mid-sized, 34.3% for large, 22% for jumbo. So a clear preference, if you will, expressed across those market segments.
Ray, do we know, when we're looking at the exposure with deductibles and the fact that those folks have access to an HSA, do we know what percentage of them do take advantage of an HSA?
I think so. Certainly not in this data. CHIA's statewide survey, though, we do a statewide household survey that does a deep dive into affordability and access to care and why you chose the care options you chose. And we also do an employer survey that asks employers why they offered what products and why you did a high deductible health plan as opposed to a tiered network product or what have you. So not in this data set, but separately, we have quite a bit of information on that. And CHIA is actually preparing, in addition to our household survey report that we release every 2 years that has a bunch of information on affordability. We're actually planning a special affordability report for later this fall.
So Ray, these numbers are sort of startling, particularly if you go back if you look at the 2-year change.
Yes.
And the shift from 20% to 28%. This may be a policy question, Dr. Auerbach, rather than a data question, but I was struck by that change and the significant decrease to 1.6% in the cost growth, and wondered if you've looked at all, you've tried to correlate the increase in the high deductible healthcare plans with utilization, and to what degree that if there was a decrease in utilization that might have affected or driven down the annual cost growth. Now, that's a kind of wonky question, but kind of as we try to make sense of these data in a policy realm, kind of is this in a way decreasing utilization, which is Ashish is going to talk to us about in the cost trends hearings, certainly does drive overall healthcare costs. Is that something you have the ability to look at, or we should take up separately?
I think it is something that we have. It's certainly not something I can answer for you sitting here today. In thinking about it a little bit, we do know that the public sector, the public payers, definitely were also contributors to the slowdown. So it wouldn't just be high deductibles, like the really strong performance at Mass Health and the slow spending growth at Medicare also suggests that this isn't just a phenomenon of what's happening in the commercial market. But having said that, the literature does say that the growth of high deductible health plans means that people will use less care. We do have some slides here on cost sharing that we're going to turn to next, and we have more on that. And I think that I guess I'm going to turn to Dave now in terms of it's definitely the type of issue that can be looked at in greater detail. I don't know if there are plans to, or what your thoughts are.
Yeah, I pretty much agree with that. I mean, we could apply some literature to see how much of the commercial trend might be affected by this higher out of pocket that people are facing in the high deductible plans. I don't think it'll explain a big chunk of it, though. It would be noticeable, but not a majority of it, I'm guessing. We could look at that.
Thank you.
It's right, it is a striking slide because you just go back 2 years, 20%. It's like, well, you have a downturn. It's a niche. At 28%, it's a major part of the market.
In a robust economy.
Yes. And once again, in the unsubsidized individual market, it's the dominant choice. And so it does say something about what, given the choice, what types of risk people are willing to, or it's not necessarily all attributable to choice, certainly, but it does say something about when people have different types of risk to deal with what choices they make. Now this slide looks much more explicitly at the issue of cost share. And so, and what this does is this is what also, of course, not from the all payer claims database, this is reported to us at the aggregate level. It is possible to drill down in more detail, but now with the data that we have here, right-hand column, the far right side, shows the total per member per month cost sharing amount. And so you see it lines up, and then also the size of the bars shows that. So it lines up very well with the kind of clout of the market segment, if you will, with unsubsidized having the highest cost sharing amount, followed by small group, followed by mid-size, followed by large. What is interesting, at the very top, you see connector care, and that's the impact of the cost reduction. I'm getting it wrong. The cost sharing, cost sharing. Yeah. Those subsidies which have now been discontinued, you see that they're obviously extremely effective in shielding people in that portion of the market from cost sharing. And what happens going forward is something we'll look at carefully and report on next year. But that remains to be seen. But you see across the other parts of the market what the relative, what the amount is, but also interestingly, just the growth rates are highly differential, with the unsubsidized having the lowest growth rate, and that might be a function of high deductible health plans. People choosing things that have lower premiums or have lower cost growth, and then in the other parts of the market, potentially richer benefit offerings. It does show total premium growth at, or total cost sharing growth, I'm sorry, not premiums, total cost sharing growth at 5.7% for the year. So once again, in the context of 1.6% growth in total healthcare expenditures, 5.7% growth in cost sharing. This takes a look at premiums and breaks it down by market sector. Excuse me. And so premiums certainly reflect the benefit package, kind of the richness of the design. And so once again, you see unsubsidized in the unsubsidized or even in the connected care market, people are buying a kind of a benefit package that is less rich, if you will. And that as you go up into the mid-size, large, and jumbo, you're getting better benefit packages. That's reflected in the per member per month premium shown on the right-hand side, where the total statewide average is 483, with mid-size, large, jumbo, and GIC being above that. Also, just interesting that the change in premiums is not a straight line correlation with the market segment. So it isn't as if all high growth rates are at the lower end of the scale. It's kind of differential: 3.8, 6.9, 5.4, 4.1, 6.1. So the premium increases have been variable across the different market segments rather than showing a strong correlation to the type of market.
So there isn't any way to sort of risk adjust for the richness of benefits in any particular package. Are there assumptions that you make about the price increases versus the completeness of a benefit package offering?
Sure.
So we didn't look at that specifically with this data set. What we have seen in our data is that over this 3-year period, we saw benefit levels trend down slightly across all the different group sizes. And I think that's reflected in the increase in high benefit health as well across all group sizes.
So what's helpful is to know that essentially the changes that occurred across the board, and we aren't here just seeing a reflection in the change in the benefit design.
Yes, we're certainly not seeing that people are getting much richer benefit packages in response.
Great, thank you.
Right, because this slide is fully insured premiums, I assume this excludes the self-insured book of business at GIC, is that correct?
Well, we have the GIC called up, so it's.
So this is only the fully insured portion of the
plus.
GIC.
Oh, plus the fully insured portion of the GIC.
Okay. So it's
Our
just
actual
self-insured.
Right. Is it just a small portion?
Right, just a small portion of the GIC, it's mostly self-insured. Right.
Any other questions before we move on? Rick?
Ray, could you just quickly tell us the size you're talking about, small group, mid-size, large, I'm just curious as to what size employers you're talking about.
Oh, yeah.
You wanna take this one?
All right.
Yes. So when we're looking at a small group that is with up to 50 employees. Mid-size is 51 to 100. Large group goes from 101 up to 499. And the jumbo group is anything with more than 500 employees, but of course, many of the jumbo employers are substantially larger than 500 employees.
And they're probably more likely to be self-insured, right? So they probably aren't reflected in.
Yeah, so we have a slide in the report that shows that when you get to the jumbo group, more than, I think it's close to 3/4 are self-insured. So of course, this is only the subset of jumbo group members who are in a fully insured plan.
Thank you.
I have a question as well, if I may.
Yes.
I was looking at, in addition to these numbers, the, later on you have the claims cost for the fully insured, and I believe those grew by maybe in the high 2.8, where these premiums grew by about 4.9. And I was combining that with the growth in the admin costs, the net cost of private health insurance, and I think that explains a lot of the gap there. Is that, have you done that, Ray or Ashley, is that what it seems to be?
We do have a slide coming up.
Ashley, do you want to come
Let's do
up
it.
and use
Right, let's-
This is definitely the phone a friend part. You can use the
I'd
mic.
like to use the lifeline.
Yeah, so
There
I
she
mean,
is.
what we did notice is that last year when we were doing this report, we saw that the premium growth was less than the growth in medical claims costs. This year, we see that the premium is more than the growth in medical claims costs. So this may be going back into that underwriting cycle that Ray mentioned earlier, and we do have a slide that's going to address some of these long-term trends.
I do this very next one. In fact, yeah, this is the one that shows that very issue of the, if you look at what Ashley was just speaking about, the light blue line shows fully insured premiums. And you see that last year, they were actually under growth in wages, total medical expenditure, and member cost share, sort of they were down. And then this year you see that they're up. And if we look back over the last, the whole amount of time we've been collecting this data, that kind of actuary, like net cost of private health insurance, you see these multi-year swings that any one year doesn't seem to be showing like a long-term trend. It seems to be more a counterbalancing of a prior year's trend. But this slide, and this is the last slide, other than some supplemental ones we have, if people want to look at them, puts out, kind of, I think one of the major takeaways, which is that the overall 1.6% growth rate is a very good number and one that we should all feel good about. But this slide shows member cost sharing over this, and this is cumulative numbers, so over the 2015 to 2017 period, has grown by more than 10%, and that is obviously significantly outpacing the growth in fully insured premiums over that period of time, the growth in total medical expenses, growth in wages, and the growth in regional inflation. So there's definitely, although there seems to be some good news on total expenditures, there does seem to be an issue around still the affordability or the cost of care. It means that the battle hasn't been won. And as I mentioned, for both employers and employees, it's a lot of this. It's not a case of, or it doesn't seem to be the data that we see isn't a matter of the employers making out at the expense of the employees. It seems to be that but once again, it could be a function of the actuarial cycles.
And I think it highlights the kind of disconnect between, we're measuring as a state, the benchmark is 3.1, we're coming in at 1.6. That sounds great. Then you talk to our members, our employer members, and they're saying, hey, our premiums went up by over 6. So it's very hard, as you know, to explain, what that disconnect is all about. But that reflects more the reality that I hear from A members, when they get their renewals, and I'm sure other folks in the room as well.
As you said, Ray, that's only half the issue. The other half is the employer is getting hit with around a 6% increase. At the same time, their employees are getting clobbered with cost sharing. So they're getting hit on both ends. And given the increase in cost sharing, utilization goes down, and it appears that our overall costs have declined.
Right, and so as I've said, all these numbers are sort of neither good nor bad. I think that what they do is they invite further scrutiny. And so that's CHIA kind of sets the table, and then the Health Policy Commission has the enviable task of actually tucking in.
Figuring out what to eat. Other comments?
But just a comment, Chairman Everett said, we should celebrate the 1.6%. As you look at the commercial Medicare, Medicaid, we should also celebrate the work of Medicaid, because that's usually the number that we see going up, and here it's the place where it's going down. So worth noting.
That's a great point, because actually compared to prior year, you can see the 2/10 and figure, oh, well, is that sort of a mass health thing? Do they always do that? No, they were actually in prior years. I think the last 2 years they were up, I want to say 4.3 and 6.1 or something like that. So a 0.2% decline is definitely a result of a lot of good work there.
Dr. Auerbach, did you want to make any particular comments or
Well,
thoughts about the presentation?
I guess just one is that I do think it's on the previous slide when you were comparing the premiums by market with the connector and the small group and the other sizes, that benefit design is probably one thing going on in there, but we know for sure that those connector premiums are so low, it's really not that they're less generous benefits or higher cost sharing, but it's a lot of it is about efficient plans and using lower cost providers and things like that we continue to look into, because it is a remarkable difference that you should see the premium.
First of all, let me just thank both of you, all of you, your entire team, for the presentation. Extremely interesting and helpful, and you're right, it does set the table. And I particularly appreciated your, not an admonition, but your thought that we shouldn't rush to conclusion about these numbers, but take them as part of our own need to set an agenda going forward. And a couple of things that really stuck out at me. One was the increase in outpatient utilization and outpatient costs, and kind of how do we, is there something there to be looked at? There isn't a decrease in the inpatient cost side, but there isn't a comparable increase. So kind of better unpacking that and understanding what's going on. Is it good? Is it bad? That part is it's not your job to say these are good data or bad data, but it's our job to understand what's driving it. I think second, I agree with Marty. We really need to celebrate what Next Health has done. It's astonishing. At the same time, the commercial increase is still 3.1%, and that's barely under the benchmark, or as most people in the Commonwealth would like that to be the benchmark. So
It will be the benchmark.
it will be the benchmark. So kind of what levers do we have to start to attack that commercial rate and drive it down, so we're not in a position of seeing increasing premiums and increasing cost sharing over time. Third, the other thing that the Commission is responsible for and working hard on is developing these alternative payment models, and to see that that really hasn't shifted. It's actually gone down in that private sector from 42 to 41%. We're not making the kind of traction, getting the kind of traction and making the advances that we had hoped for. So that's another policy issue that emerges from your data. And finally, since I'm the self-anointed queen of readmissions, we skipped right over the fact that the readmission rate has not changed, and 16% is not a number to be celebrated. So I know that's going to be a topic at the cost trends hearings. It's a topic every year because we make no advances, but really an interesting area that it's time for us to tackle.
And I would like to say that in the area of readmissions, CHIA, in addition to doing our annual reports on the subject to try to once again establish the factual foundation for the discussions, we've convened a bunch of state agencies and also private sector organizations like the Mass Hospital Association to look into better ways of doing risk adjustment for social determinants of health. Because right now it's fairly primitive the way we do risk adjustment for social determinants, and so when you look at things like readmissions, there's probably some good readmission happening or things driving it that we aren't seeing because the risk adjustment approaches we use are too crude. So we have a really strong group of people from CHIA, from the Department of Public Health, from the HPC, from Mass Health and Hospital Association and others looking at, with the available data sets that we have in state government that we can tap into, could we do a better job of modeling and accounting for social determinants so that we're not quite as crude in measuring these things. So it's definitely an area we're quite interested in and would like to have better data on.
Great, thank you. And thank you for a fabulous presentation and for just a spectacular piece of work. We'll look forward to hearing your presentation at the hearings in October.
Thank you so much. Thanks.
Okay, let's shift to our next topic, and I'm going to turn it over to Commissioner Cohen, who's chair of the Care Delivery Transformation Committee, to do the introductions.
Thank you, Wendy. So cost is, as we know, only one dimension of care policy and access and quality are the other dimensions that we want to look at. Back in 2016, the Health Policy Commission had a $6.6 million healthcare innovation investment fund that we were able to fund a number of grantees to look at innovative ways to reduce cost and improve quality of care. And today we are fortunate to have a presentation by the folks at the Brookline Community Mental Health Center on work that they have done with actually one of our certified ECO partners. So we are pleased to have their presentation, and I'll ask the staff to do the proper introduction.
Thank you, Commissioner Cohen, and thank you, Commissioners. As the Director of the Strategic Investment Team, I'm just so pleased to have representatives from Brookline here today to talk about their the work they're doing. And I'll ask Brooklyn Jones, Senior Program Manager on my team, to make the introductions.
Great, thank you, Kathleen, thank you, Commissioners. It's a distinct pleasure to introduce yet another one of our intrepid awardees to you all. I think with the presence of Dr. Henry White, the Clinical Director of Brookline Community Mental Health Center, and Hannah Scott, the Director of Strategy and New Business Development. You see before you an example of one of the 10 Targeted Cost Challenge Investment awardees. Recall that back when we made these awards, there were a number of challenge areas that we had issued as eligible for innovative approaches to cost reduction. In front of you, you see one of our behavioral health integration awardees, and I would serve them up to you as an example of one intrepid lever to use as a very refined model of approaching social determinants of health and leading them into the best kind of care for some of the most complex and vulnerable members of the Commonwealth. I'm excited to have them present to you the 9-month interim results, which are very impressive. I would say that of note, especially from having watched them develop this personally over the last, I think, 15 months of intervention, but we'll hear the 9-month results of some of their patients. The resourcefulness of this team is something that is really exemplary of the awards and everything that we had hoped to see when we funded this one, not only on the patient level, where they serve to bridge so many of the complex needs and other teams who are focused on these patients, but in typically siloed areas, and bridging that divide with their partnership with BidCo and their ASAP partner in Springwell. But also on the macro level, it's hard to go to a meeting without seeing Dr. White there, who's advocating for these patients and driving some other new way of serving them, and apparently will stop at nothing. They are partners to the Community Care Cooperative Award through the Shift Care program, and so we're looking forward to seeing the expansion of that, and I know you'll talk a little bit about that today. So without further ado, Dr. White and Hannah, please.
Thank you very much for inviting us, and thank you to the commissioners as well for having us and tell you about the work that we've been doing over the past now 7 years. So we came somewhat early to this challenge of working with what was then called equalizers, now called high-cost, high-need patients or complex patients. We're going to tell you a little bit about this population and how we come to understand them. They are part of that 5% of the patient population who represent, anywhere between 30 and 50% of the cost, depending on how you structure it. We've learned a lot, and we think we have lessons that are really applicable as the state moves toward ACOs across the board and other kinds of payment arrangements. We want to share those as well. It's been, for me, I think the work really began with, in a personal way, how as a new psychiatrist ended up working in policy area really came out of the fact that our patients at my mental health center, just like mental health centers across the country, were dying young, typically 20 years younger than their healthier counterparts. So once that became known, and that was really common knowledge maybe 10 or 15 years ago, we really wanted to explore what was going on. We knew it wasn't simply a matter that they had sicker from the beginning, but there was something in the way these patients interacted with the systems that was supposed to take care of them that wasn't going right. So essentially we adopted an ethnographic approach. We went out and we went into the patients' homes and tried to understand this. And what we found was typically these patients were at the intersection of three domains of problems. Truly, they had the great misfortune not only to have often serious mental health concerns, but also pretty serious social determinants of health challenges, and often common but potentially life-threatening medical problems. It turns out, as you can imagine, that having three problems of three different types is becomes if you would, a complex system in which that is self-reinforcing. If you have trouble accessing care and you have diabetes and depression, it means your diabetes is going to get out of control. As it gets out of control, you get more depressed, you become less able to adhere to the treatment strategies. And the result of that are frequent readmissions, often a lack of being able to follow through as an outpatient basis, frustrated providers, unhappy patients, and in the worst case, early deaths. So that was one of the key lessons we saw, was that it really becomes a causal chain, a self-reinforcing causal chain between these three kinds of domains. The second is that the systems that are determined to take care of these people, whether it's the social service systems, care systems, health systems, as has been emphasized here, and the Commission has really been exerting wonderful leadership in really making sure that there is a movement toward integrating social determinants of behavioral health in our system, but they are separate. And so that all they see of these patients is one small part of what is really a whole. And none of them can really understand and see how these three sectors interact with each other. Second, there's a lack, there is a lack of integration. So the only person who really knows the whole picture is the patient themselves. And these are patients who often are very challenged, sometimes emotionally, sometimes intellectually, certainly physically, and they're really not in a position in order to link together systems that speak different languages, have different electronic systems, often represent different geographies and so forth. So what we elected to do was really develop an approach that at least would bring in some other caregivers who could see the big picture from the patient's perspective, really see the full view of that. So as I mentioned, we began in our mental health center back in 2010 with a group of patients who were seriously mentally ill and had serious medical problems. We quickly learned that really moving toward better integration was was gonna be a key to their success. I think we were pretty good about engaging the patients, but we felt that without full access to their medical team, we're really gonna be awkward. So in our next iteration, and with a grant from RWJ and from the Blue Cross Foundation, we began to partner with BIDCO and located a team at Healthcare Associates, which is their primary care practice at the hospital, and worked with patients who were part of that system. During that same time, we really developed a methodology in order to identify the patient population. Our first thought was really just to use the statistical methods and start with the superutilizers, people who had 10 plus hospitalizations plus several ED visits per year. And we found that while that gave us the population of patients, it really lacked the dimension of clinical care that comes from actually talking with the providers who are also working with those individuals. So we began to shift where we have both the data analysis plus the warm handoff from care coordination teams or other similar kinds of programs. As we developed some success in working with that population, we really wanted to see if this would work with a different population of patients who are not just hospital connected. So we began working with the Bowling Street Health Center in about 2014. And what we found there was that even in a very high functioning community health center, there were patients who virtually lived across the street from the center but were not being able to access care because of transportation, intellectual or developmental disabilities, a host of other problems that literally kept them crossing the street and getting to their providers' offices. And then, and with the grant from the innovations program, we were able to look at how it would work if we would integrate our program with a care coordination team. So BIDCO has a care coordination team that's located in their main offices in Westwood. And so we located a team of our staff in those offices to get to both work with the population who are identified first with their spend of over $50,000 a year, their degree of utilization, but also who had really failed out of what was standard care coordination approaches where they have a wonderful team of nurses, but it's largely telephonic, and many of these patients, fundamentally lack telephones, so they're not going to be able to succeed in getting linked to care with that kind of methodology. So we will talk a little bit about what our approach is and some of our success in with this population.
So I'll shift a little bit and talk about the model that we've developed throughout the years that we've been developing a Healthy Lives program. And the first thing we'll talk about is the team, and I can't stress enough how important it is and how important the staffing is. It's really the key to our success, the skills and the competencies of the staff that we hire, and that we continue to train as we practice this model. So currently we have a team that's managed by either a nurse care manager, an RN, or a licensed social worker. And we practice both models. We've also done a combination of the two. And it really depends on that team leader being able to understand the interaction between all of the determinants of health, including the medical, the behavioral health, and the social service needs, and how they interact together, and really being able to impart that wisdom onto the bachelor's level community health workers that we need. I should point out that the definition of community health workers can be variable, and the community health workers that we recruit that we've found have been really successful in this model are folks who are at the beginning of their career, who are seeking to go into a field such as social work, psychology, nursing, or medicine, who are really looking to commit to a couple of years to learn this model, to learn the interaction of the different systems, to learn about patient care and how healthcare works. And we commit to training them, teaching them, and really moving them on to the next phase in their careers. So we're also really proud that all of our community health workers have successfully graduated onto a graduate program of their choice that they determined when they came on, which includes social work, psychology, medical school, and nursing school. And a great example of needing to have the knowledge of how things interact together is something that we come up against all the time.
which is folks that have mobility issues or other issues getting to appointments. And the need to really understand how those issues, how the pain they may experience may exacerbate their medical issues, and how it may be related to the travel and the appointments that they go to. So really, to have a team that can sit down and understand what appointments are necessary for the client, what appointments may be stacked one and the other, so they're minimizing the time that they spend outside the home, all the available home care that might be there, and the transportation options as well. So things like this come up all the time that's necessary for the team to tackle and necessary to figure out together as a team. And the last point I want to make is that this is a team that we feel is quite cost effective. And we've been trying different models with this as well. With C3, we'll talk about a new initiative that we're doing to try to minimize the cost of the team and expand the effectiveness of the model as well. But this team of a nurse care manager, a social worker, and 2 community health workers can serve about 50 patients per year. The approach that we use is really to begin with a patient in their home. We do a lot of home visiting, we do a lot of community visiting, we set aside a lot of time, and that's the great part of using the community health workers, that we are able to free up their time to really get into the home and spend some time building a relationship with the client. And it's really to understand not only the problems that are going on that have been identified, but who's identified the problems, who feels that they're a problem, what does the patient feel are the problems, and what are the strengths and the resources that the patient possesses as well, and how do they interact with each other. And really, I can't stress enough also the capacity that the team has to be flexible and creative and really understand the comprehensiveness of the problems. The other thing that we should note is access to the EHR, so not only understanding the patient from their home, from their report, from provider's report, but also Dr. White mentioned the need for integration, and we've really found that that's a key part of this initiative, is that we need to be able to access the medical record to understand when patients have appointments, who they have appointments with, what was said in that appointment, what the follow-up that's necessary after that appointment, and to be able to communicate with those providers as well in a secure and effective environment. The intervention itself is 6 to 12 months on average, so we don't aim to go in and begin a patient's life forever, and we tell them that from the start. Our goal is to really form a long-term team around the patient, and there are supports that are out there. I'll give a shout out to the PACE programs and to the CCA One Care and Senior Care Options programs. They're often great places for our patients to get long-term care, but it can be really tricky to transition somebody over into programs, or even tricky to identify what programs might be most useful and most suitable for that patient. And a lot of the providers that we interact with are wonderful and provide wonderful medical care, but aren't aware of all the different programs that are out there and what it takes to transition over. So really what we try to do is look at, and with the patient and their providers, to identify what an ideal system would look like around this patient. What does this patient need? It might be the PACE program, it might be the One Care program, it might be VNA supports, it might be bringing in family to help them manage their medical needs, it may be moving to an assisted living facility or skilled nursing facility if necessary. And once we identify that, helping patients work towards it. So it really can be quite complicated. A lot of times it can be not only educating people in terms of what's out there, but also helping them manage their finances to make sure that they're eligible for programs, helping their families understand what the programs are, how the family can help with that. We had one situation where we had a gentleman who desperately needed the services of the PACE program and wasn't eligible because he had too much money in his bank account. But he had too much money in his bank account because he couldn't see and he hadn't been paying his bills for his rent for months. So once we were able to identify that, help his family understand what it meant to be a rep payee, a guardian, or have power of attorney and help them with that, they were able to help him with his bills to spend down and enroll in the PACE. And that stopped an incredible cycle of being hospitalized almost every week because he wasn't able to get to appointments, he wasn't able to read his medications, he wasn't able to get home care because his current insurance provider wasn't covering the services that he needed. And we'll just talk a little bit about another patient who, in my past life, I was the nurse who was actually going out to see patients on this program. And this is one of my first patients who I think really exemplifies the complexity that's out there, and also just the variety of programs that we need, the variety of problems that we need to be ready to tackle. And if we're not experts in that area, to be ready to find somebody who can help us tackle that and help our clients tackle that. So this is a patient, we'll call her Susan. She lives on a low fixed income of Social Security. She also lives in subsidized housing. When I met her, she was in danger of eviction. She had a lot of outstanding rent that she needed to pay, as well as there had been a change in the requirements of subsidized housing. There was no longer smoking allowed in housing. That was causing a real problem for her. She was a 2-pack-a-day smoker, and her neighbors had complained, and she was actually in the process of going to court and being evicted. She was very isolated, no social supports, no family. She was closest to 2 sisters, and both sisters had passed away in the previous year. She had type 2 diabetes, obesity, and congestive heart failure. She had been inpatient for over 3 weeks after an exacerbation of congestive heart failure, and then in a SNF for another 2 before I met her. And prior to that, 2 months prior, she had an inpatient stay for behavioral health concerns as well. As I mentioned, she's a heavy smoker. Her behavioral health concern, she was diagnosed with bipolar 1 disorder. She's very distrustful of providers, had fired a string of primary care physicians, so she was actually refusing to go back to see outpatient primary care when we started with her. And she has and had and continues to have pretty poor executive functioning skills. So very smart woman, but things like paying bills, keeping on track, managing appointments, all of that was challenging for her. So we were able to come in and help Susan consolidate her debts, which was huge for her. And again, that's not something that every care coordination program would be able to do, to sit and spend the time with her, to understand what it meant to be in debt, to understand what it meant to have enough in her budget to pay her rent consistently, and to figure that out going forward so that she would be able to sustain her housing. We were also able to step in and collaborate with housing to go with her to court to help them understand why she was having the issues she was having paying her rent and how she was getting support to make a more sustainable plan moving forward. And then connect her to service providers. So we were able to connect her to people who could help pay some of her back rent, which was a huge challenge for her and wouldn't be possible. And also to connect her with things like homemaking services and folks who could help her in a case management capacity moving forward, paying her bills through the Elder Service Agency. We also were able to provide her with meal planning and delivery, which not only cut her costs, but helped with her diabetic care. So she lost a considerable amount of weight. We started doing daily weights with her, which was as easy as getting her a scale and explaining to her what it meant to do daily weights and why it was important to record them. She'd bring the paper to her primary care physician, and then they were really able to get control of her diuretic medications to get congestive heart failure under control. We are able to attend appointments with patients as well, which was hugely helpful in this instance and in many instances, because a lot of times the providers don't have an understanding of what's going on at home, what the resources are at home. I think a lot of patients are quick to report that they can do things when it might be a challenge for them because there's some shame. There's also, some nervousness and anxiety when patients are going to appointments and they forget to mention what it is that they really wanted to mention. It also gives us an opportunity to bring up things that may have been a challenge for patients. So we are often finding out things that the providers wouldn't necessarily know, like patients who have a lot of challenges reading medication bottles and administering medications themselves that wasn't otherwise known. When we do med reconciliations, we'll look at the pills and we'll notice that one patient had 18 pills to take in one day and 13 of them were round and white. And he wasn't particularly good at figuring out which was which. So that was a real challenge for him and a real challenge for us, but something that wouldn't be known unless you were able to take a look and really literally spill those all out in front of you. So Susan also, we were able to work with her on smoking cessation. She identified that she wanted to be able to stay in her apartment, but she didn't necessarily want to quit. So we allowed her to work on that, and she cut back to less than a pack a day, which allowed her to stop smoking during the night, which was when it was hard for her to get up and go outside and smoke outside the apartment. So she was able to cut back enough so that she was smoking during the day, and during the day she was able to get up and go outside. So she was able to keep her housing, thankfully. And then really the integration of the care team that exists. So a lot of our patients have a lot of people in their lives. They have a lot of providers in their lives. They have a lot of people providing care for them. But those providers don't necessarily talk to each other or understand what the other providers are doing, what their value is, what they could be doing, and the problems that the other providers have identified too. So we feel it's really our job to hold that common understanding and to impart that to all the providers in the team. And it's really important for us to understand the workflows and the capacities of the providers as well. So we need to understand that we may need to get a letter signed by a primary care doctor, but it's up to us to draft that letter first. Because if we wait for the doctor to draft it, it's gonna take a long time, and this is, of urgent necessity. We need to understand what information it's important to communicate and how to communicate that effectively. So if there's something that really needs to be known, how to write an effective EHR note, or maybe if that's not going to work, to actually show up at the appointment and talk to the provider face to face. And really, I mentioned before, a focus on relationship building. This is an intervention where we're seeing people regularly. We're going into their home, usually in the beginning, at least once a week, to get to know them, to form a trusting relationship. And often these folks are not trusting of providers because they've been let down in the past. There are a lot of needs, and it's hard for providers to meet those needs. So for us to come in and make sure that we are delivering on what we promise and we're showing up every time, and sometimes it's really difficult to even show up. There are folks who don't open the door and don't answer the phone, and we are pleased that we have the flexibility and the coaching from our team to continue to show up, to continue to be on the doorstep, to find a way to connect to that patient, because we do find when we connect, it's very successful, and we have very few patients, if any, in my memory, that once we connect with them, don't want to be involved in the program. And lastly, really concrete assistance with tasks. We have a lot of folks who struggle with this, and there are a lot of challenging ways to find that as a provided covered service as well for folks who can't afford it. So homemaking, transportation, bill paying, all those sorts of things are something that we always think about, and for Susan in this instance, it was really important to connect her to. As Griffin mentioned, these are our 9-month interim outcomes, and I was really thankful to CHIA for mentioning how difficult it is to get accurate cost information on things that just happened. So we are very hopeful that we will be able to have some cost data, and we've certainly set aside some funds for investment in a robust data analysis at the conclusion of our grant period. But in the interim, we have been tracking utilization data to make sure that we're on track in terms of cost savings and improving health outcomes. So this data is based on 41 patients that were enrolled at least 9 cumulative months, consecutive months in the program. And you'll see that per patient per year, we are seeing a decrease in inpatient utilization. We're seeing a decrease in emergency department utilization, and we are seeing a small decrease in 30-day readmissions as well. I think a big part of this data and a big part of the success is managing care transitions for these folks as well. I know that a lot of interventions are targeting care transitions, but for us to be able to really help the inpatient team when our patients are inpatient understand what home really looks like, and what the supports at home really look like, and understand what we need to get in place before that patient goes home, or if it's appropriate for that patient to go home at that moment, is really something that's helping us keep people out of the hospital and certainly affecting those readmissions as well. You'll see in orange at the bottom that 68% of our patients have shown improvement in a relevant outcome selected at enrollment. So for folks, we do select a health outcome measure that is relevant to them. So a lot of times that's A1C and maybe systolic blood pressure. It could be pain rating, and then we track whether that improves over time. We do see a considerable improvement with our diabetic patients in previous iterations, and for this as well, we do track that separately. In our last grant period, we found that 85% of our diabetic patients had a decreased A1C, and the average change was 2.8%. So that's something that we've really been able to affect, and I think a lot of that is being able to understand, although on paper and the evidence-based practice may be that a diabetic regime will work if somebody's testing 3 times a day and doing sliding scale insulin and also doing a long-acting insulin, that it's important for our providers to understand the capacity of the patient and the resources of the patient, And although it may be best on paper to give them a sliding scale on a long-acting insulin, if that patient isn't able to do that and isn't able to bring in a BNA to help them do that in every instance, it may make more sense to give them a simpler routine. And that's a lot of times what is really effective for our patients, is really understanding what the best routine for them might be, that they can really feel confident in administering and comfortable and fits their home environment and their lifestyle. And the yellow box at the bottom is our homelessness rate. We had 18% of patients reporting homelessness or instability in our housing situation at engagement, and after 9 months we have 2%. A lot of that, as I mentioned, is helping people connect to resources for financial assistance, to better understand their finances, to stabilize the housing that they do have. Finding housing, as I'm sure you're all aware, is a very, very challenging intervention for everyone due to the lack of housing and difficulty connecting with housing as well. But it's something that we put a lot of time and energy towards, and certainly improves health outcomes dramatically when we are able to help people with that piece. And we often people identify, we'll go into people's homes and their providers will say, can you please help them? They never come to appointments. Their A1C is out of control. They're, looking at a kidney transplant if they don't get their blood pressure under control. Can you help them with those things? And we, of course, target those as interventions, but also ask the patient what their greatest area of need is. And often it's housing instability, issues with money, finances, issues with family interactions, all of those things. And so we try to target all those at once to make sure that we are targeting something that's really important to the patient, and the housing is often that.
I just want to emphasize that the patients that we selected for this particular project were folks who had been identified as having spends of over $50,000 a year, even though, as said by the previous presenter, that the claims data is often lagging, so difficult to get that up to date. I think that's continuing to be a challenge. And in addition, have problems in all three of the domains that we talked about. We wanted to just put a little context in how our work fits into the spectrum of care coordination. I think one of the things that as ACOs and other entities have developed care coordination, it often is described in a very generic terms, but just like there are levels of intensity of medical care coordination itself really has multiple levels, and it's really an area of very active, I think, needs, or there's a lot of needs for staff development in this. Usual care is very little care coordination. You should know, though there is some. In primary care practices where they have moved care coordinators, and usually it's about a 1 to 1,000, 1 to 500 to 1 to 1,000 ratio, which basically means 1 to 2 phone calls on your behalf as you pass through, if it's not a terribly busy day. With the care coordination program like at BidCo that we are currently headed with, it's about a 1 to 200 to 1 to 300 ratio. It's completely telephonic. There may be some home visiting, but it is essentially limited by, first of all, people who have problems that can be managed with a telephone, and for patients who have telephones who haven't burned their minutes for the month. And for this population that tend to be low income, tend to be disorganized, that is often one of the barriers to care. Our population is more intense. It's about a 1 to, and an active patient, it's about between 1 to 25 and 1 to 50. It's time limited. Our intervention really pushed it down to between 6 and 8 months. We usually are able to stabilize people after 8 months, but it's intense, and it does involve going up to where people live. I just want to emphasize again, it is truly impossible to run a healthcare system if you don't know what the problem is. I mean, it would be like doing medical care in the days before X-rays. If you can't see it, you can't diagnose it. It's just a matter of guesswork, and with busy providers, whether they're social service providers or behavioral health providers or medical care, simply aren't able to see the whole problem. And it's only when you join the patient that you really see where the point of intervention is. So I want to just finish up with what our next step is, and we're very appreciative of the HPC investing again in our work through our collaboration with C3. We're very excited about this because they're really shifting. One of our takeaway lessons has been that programs like ours truly need to be integrated into care delivery. The extent to which we separate it from it really, I think, inhibits our ability to be effective on the moment and to make sure that all of the levers of care are pulled when necessary. So we're shifting to a technical assistance role with C3 and working with several of their sites across the state to really help them develop teams similar to the teams we have developed. So we're very excited about this. Mental Health Live Advocates is also involved in this project, so that will also help us develop services for teens as well as for adults. We hope to, our fundamental belief is that all ACOs need to have, just as all the ACOs have intensive care and a whole range of intensive care options for people with serious and complex medical problems, they really need to have this kind of intensive care coordination that really meets the patients where they are. So I think the core is that you really can't treat something effectively if we don't understand it. And it's only when we're able to really pull the problems together from the patient's point of view that we can understand it. So I just want to finish with really what we take away points as far as the policy. First, I think this population, if you look at the high cost, high need patients, really there are many subsets within that. Some are frail elders. Our patients tend to be a little bit younger, between ages about 50 and 70, and they have these problems and three domains that really are self-reinforcing. And without intervention, they will be persistently high cost, and the results are really poor outcomes, poor care, and often calamity. Second, an approach to them really requires a community-based approach. And as a community psychiatrist, that's really what we brought to this. The current systems are office-based. I mean, even though there's a shift to hospital care to outpatient care, for this group of patients, you really need to get out to where people live if one hopes to kind of get a handle on what the nature of the problems are. And it has to be flexible. Hannah mentioned meeting the patients where they are. It isn't the problems that we might identify the uncontrolled diabetes as the priority. They may identify that they have their chronically ill mother living with them and they don't know what to do. So they're not showing up to appointments. So you really have to know what the patient's view of their whole world is. It's a very simple takeaway, but it actually doesn't happen. Finally, there's a lot of workforce development here. I mean, all of us train in one of those domains. Few of us really understand all three and are effective in moving back and forth. Co-location is a step in that direction, but it's very different than practitioners like Hannah who understand both the behavioral and the social and the medical dimensions of people's struggles. Otherwise, the only person who's going to be doing the integration is the patient themselves. And finally, integration is key. When we started, we were not integrated in the health records of our partners, and it really was as if we didn't exist. If you're not in the record, you can't intervene. The providers don't know what you're doing. We don't know when someone's in the hospital, when they left. So integration is key, and that's one of the reasons why we really want to help ACOs develop these kind of teams as our next step. So we'll stop there and be happy to take any questions you have.
Okay. Just wonderful presentation, great results. So in the case of BIDCO, they're obviously buying the relationship with the Brookline Community Mental Health Center. Any thoughts about that question about whether this is best done in that kind of relationship, or do you see it as one that could be done by making the team, as you suggested, within their own domain?
I think that's what we're about to find out in our next iteration with C3. I think we think that it's definitely worth investigating due to the need for the level of integration that makes this intervention so successful, to do it from inside the ACO with access to, they have their own care coordination system, and then that allows a handoff from their less intensive care coordination into this new Healthy Lives Life program that they're developing. And that makes that seamless, as well as the the ability to access the EHRs that their providers are using as well, which is so essential. And we really feel that the value that we bring as providers to this intervention is the knowledge and teaching of the model, how to understand the patients and how to understand the interactions that are going on, and how to identify, as Dr. White says, the levers that we can pull and when to pull them. And we feel that we can do that by teaching other providers, whether that be within a system or coming in from outside the system. So I think it's a great question, and we shall see.
And the other reason why I think we believe both in terms of scaling works better if it is integrated. Second of all, I think we believe this is where healthcare should go. You know, and I think that the days of I only deal with a medical problem and the social worker who I don't even know their name is going to manage their housing and someone else and psychiatrist who I exchanged a phone call with 6 months ago will handle the medical. That doesn't work for this population. You know, we truly need providers. This is really where the workforce development comes in, who can work in all domains comfortably. I mean, I don't think this exists. And it's also, I think, a correct understanding of patients. I think we tended to look at patients through very narrow lenses. And in fact, if you go out to where patients live and join them there, you're dealing with all kinds of things. And as providers, I think we need the capacity to do that rather than the hyper-specialized way that medical care has gone. So we're trying to, at least for this, I don't think you need the hyper-specialists, but for this population, you need people who can think broadly and flexibly.
Just a question for Kathleen. Are we doing anything to sort of take this information and share it with our other grantees who are working in similar domains?
Oh, absolutely. I mean, program management team works with the awardees and tries to do cross-learning opportunities where possible. We also have a very robust evaluation model in place that we look forward to talking with you about at the committee level to really ensure that we're studying the implementation and impact of these models and the scalability and then sharing those lessons learned and those promising practices. So absolutely.
I think I would add only that I neglected to earlier, but Brookline Community Mental Health Center is one of 4 awards that will be highlighted in our study that Brandeis is doing on care coordination, specifically because we see this model as having such potential for scale and being really transitional for how population health and care coordination is done. So pleased to be sharing the results of that next year.
Excellent presentation. Have you been able to calculate some form of ROI based upon your results? Because that would be really important.
Well, we're, with, as the previous speaker said, in terms of getting claims data currently, we're still working on that, so we'll know that. In our previous work, which it looked like we were doing savings of about $20,000 a year, where the annual spend was about $100,000. So it was, it's very significant. I mean, that's what we've seen. Many of our patients are rapid, I know we were talking about readmission, rapidly readmitted because they had such difficulty following through on the treatment plan that was written when they were in the hospital. And that's something that we can see pretty quick turnaround on when we start to interview with people. We're interested to see, that's what part of what we're interested to see with this project is whether we'll be able to do that again. But there's a lot of extra utilization that we see when we come into folks and start working with them, simply because they're so overwhelmed with other things that their medical care tends to be their third priority instead of their first priority, and they just end up cycling through and generating very large bills.
And you can get claims data in some sort of application that you've built where you can actually target those particular claims that are important.
We are working with BigCo to use their tools in order to get us a cost analysis at the conclusion of the grant.
Great. I was really privileged to be on the proposal review and selection committee, which was a very, very hard job because we had such terrific applications, and I can't tell you how wonderful it is to sit here and see what you've been able to do with a small amount of grant money. within this innovations program. So congratulations and thanks to you for the work that you've done, and special thanks to the commission staff for just having put together such an incredible program and a great process. Thanks, Marty. Anything you want to finish up with? Griffin? Yeah, very, very exciting, and thank you so much for taking the time to come and share that with us.
Thank you very much.
You're welcome. So just as we adjourn, I wanted to remind people and reiterate what David Self said at the beginning. Our next meeting is Thursday, September 27th. It will be from 11 in the morning till 2 in the afternoon here. Unusual time, usual place. And that will be a very important meeting. Colleen, any closing remarks?
No, that's it. Thank you so much.
You're welcome. So thanks to all of you and to the commissioners, and the meeting's adjourned.